this. Over to you, Doctor, and
Thank
we
you.
will take questions from the audience later. Thank you.
Thank you so much. Thank you for having me. And like I said, allowing me to lend voice to this cause. So I choose to speak on the silver lining in cancer care, which I would like to focus on personalizing cancer screening. I have spoken much about personalizing cancer treatment. This is about personalizing cancer screening. And there is a man that is jumping from the past into the future. And the thought is to really salvage the future of oncology care in India. So I lead the Medical and Precision Oncology Division and the Clinical and Translational Oncology Research Division at Sir H.N. Reliance Foundation Hospital and Research Center. I was a consultant in medical oncology, just as outlined at Dana-Farber Cancer Institute, which is the flagship cancer institute of Harvard Med School or Harvard University, and a consultant in medical oncology at Columbia University Medical Center. I also co-chair the Asia Pacific Coalition Against Lung Cancer. I'm a member of the Lung Cancer Policy Network, and I'm a vice chair of Worldwide Innovative Network for Precision Oncology, and so on and so forth. I run multiple not-for-profit efforts and also multiple for-profit efforts as well. These are my disclosures. I begin by presenting a slide, which is a dated slide, but which holds true even today. In the right upper hand corner, you see the numbers. 1 in 2 men and 1 in 3 women will be diagnosed with cancer in their lifetime. These are numbers from Globocan 2023. And so these are real numbers wherein it is essentially to communicate the message that cancer is a common problem and it is being described as an epidemic, mainly because of the rising numbers and the prevalence and the reality in our homes, our lives, our communities. And when you look at cancer, it is a civilizational challenge, and global cancer burden continues to rise. We see the projected bar here from 2040 of 27 million people being affected with cancer globally. Early detection is the only answer to controlling cancer, because when we detect early, and you can see here, when breast cancer gets detected in a late stage, only 31% survival at 5 years, versus early stage, you have almost 100% survival at 5 years. Similarly, if you look at colorectal, if you look at ovary, if you look at kidney, if you look at lung, liver, not that much of a difference, but prostate, bladder, pancreas, stomach, breast, everywhere early detection leads to much higher survival and much better quality of life than when we normally detect our cancers. The Apollo Cancer Centers came together to name India as the cancer capital of the world. Whether that is a reality or a query to deliberate upon, the reality is very stark in terms of the cost of cancer care. And when you look at this figure here, the red bars represent the cost out of pocket. And so 70 to 80% of cancer care is happening out of pocket, and only 20 to 30% is covered by insurance or funded. When we look at this curve in the center, it shows only 456 clinical trials serving the cancer patients in the year 2023 in India, when most novel drugs in cancer care are available mainly as a means of clinical trials. When we look at this model, my proposal This is a borrowed slide from my presentation at the United Nations in 2025, where I pitch the hub and spoke model and I pitch precision. So this is Precision Oncology Clinic or Precision Oncology Center, and a hub and spoke model wherein we practice as leaders in cancer care, we practice and guide multiple spokes constructed throughout the country. And we discuss and practice not just cancer awareness and screening, but treatment, precision, clinical trials, and patient advocacy, which is centric to the way I practice medicine. Precision medicine and personalized therapy are interchangeably used to describe the right treatment for the right patient at the right cost every time. Precision is an old concept because we don't give anyone's blood to anyone. We transfuse blood only after a cross match. And that's the motto to propagate and practice when we talk about precision oncology, to identify biomarkers and then construct strategies for therapy that are very, very personalized and focused to how that patient is behaving, that patient's tumor is behaving. This is a concept that I learned as an intern when I started out at Sloan Kettering Cancer Center way back in the early 2000s. And these three are my mentors, Dr. Aarti Huria, Dr. Maria Theodolou, and Dr. Eileen O'Reilly, all stalwarts in oncology at Sloan Kettering Cancer Center back then. And there I witnessed a very transformative and seminal presentation by Dr. Richard Rockefeller, who was one of the Rockefeller brothers. Rockefellers constructed a Rockefeller Center of research right opposite Memorial Sloan Kettering Cancer Center. Dr. Richard Rockefeller had been diagnosed with chronic myeloid leukemia, and he was one of the patient advocacy voices who pitched for early fast-track approval of a drug called Gleevec, which was the precise drug for chronic myeloid leukemia and transformative in changing the survival from 20% long-term survival to 90% long-term survival. And the patients that were treated on this clinical trial actually have gone on to live for normal lives for 20, 30 decades and are living examples of precision medicine. Fast forward to my time at Harvard Med School when I was a junior oncologist and a professor there at Dana-Farber Cancer Institute. We served a patient, Mr. Ali Ali, and Ali Ali had advanced cancer and again was treated with precision-directed care and with remarkable results and responded to precision-directed therapy with cure disease. Vision for precision medicine is through genomic analysis, transcriptomic analysis, other biomarker biopsy discovery, and also with liquid biopsy, which is a simple blood test through which we are investigating multiple markers in a patient's blood and tissue. Cancer care in low middle income country can generally be divided into 4 areas. I propose not just the diagnosis and the treatment in a focused way with precision in the background, but also prevention and screening. When we have tackled the battlefield with diagnosis and treatment, we are able to leverage prevention and therapy. And a couple of slides here to demonstrate what precision medicine is doing. This is stage 4 lung cancer with a Christmas tree pattern of metastatic spread of lung cancer. And here the patient was found to be ROS1 gene rearranged. And just with precision-based oral treatment, ROS1 directed targeted therapy, this patient then completely resolved its disease, went into complete remission, and remains in complete remission several years after diagnosis. This is a patient with MSI high gastric tumor, where again immunotherapy worked magic after being diagnosed with a genetic feature of MSI high status. This patient responded to immunotherapy, off all treatment for the last 3 years now. And this is just a slide presenting my patients, Mr. Sanjay Dutt right in the middle, advanced lung cancer, stage 4 lung cancer, and what a remarkable recovery with precision-directed immunotherapy, found to be with a PD-L1 being very high, and having a complete response and complete resolution now off treatment for the last 3 years, made it into 5 years now, living example of precision success. And you see here the very elegant looking young woman in green jacket. She's a celebrated retina surgeon who is with specific type of breast cancer called HER2 positive breast cancer, and remarkable response and recovery, and many such patients here being celebrated. And I show their picture with their permission. Having said that, cancer is being described like the Dashanana, having 10 heads. Like a Dashanana, you kill one head, the other head will surface. And that's where it becomes very important to change gears, to switch gears and attack early. So early detection of cancer can save lives. We have the standard, the routine screening programs, and I see nearly 200 people have joined, and I pitch early detection and screening once a year as a mandatory engagement for all of us. And I question here, how many of us have screened this year? And let us make screening revolutionary. Let us make screening the regular matter of discussion every single time we meet, and ask each other, ask ourselves, how many of us have screened this year? And make it pivotal and central to our topics of discussion. Buy each other screening vouchers for birthdays and make that as a pitch integral to our lives, because of how early stage can truly transform the survival outcomes for people. So of course, the standardized screening protocol for oral cancer, breast cancer, thyroid cancer, lung cancer, colorectal cancer, cervix cancer, prostate cancers are all there. But then there are many cancers that don't have a standardized screening. And that's where my body of work in early detection with multi-cancer early detection test as a liquid biopsy comes in. We are now able to project blood tests for 70 types of cancer detection. There is TrueCheck by Datar Cancer Genetics, and there is cancer spot analysis by Strand Genetics that is already out there for us to engage commercially in and do the testing. I say perform the test once a year, and at least it will give you a risk stratification for low risk, intermediate risk, and high risk. At Precision Oncology Center at Reliance Foundation Hospital, we perform precision not just in therapy. In our precision clinic consultation, we have multidisciplinary tumor boards, we have clinical trials, we have cancer navigation programs, but we also have and practice precision cancer prevention strategies. So my pitch for today is for you to engage in precision activities, more so in precision diagnostics for prevention than forever needed for therapy. So this is my last slide. My strength comes from my patients. And of course, we work as a team. We have here the outreach program at Reliance Foundation Hospital led by Dr. Sewanti Jha. We have the patient navigation program led by Dr. Chetan Madre and Sister Gina. We have the clinical trials division led by Dr. Shailendra Jha. We've just founded the Liquid Biopsy Foundation of India together with Dr. Prashant Kumar. I'm an integral part of the Lung Cancer Policy Network and the Asia Pacific Coalition Against Lung Cancer. And we performed high-risk lung cancer prevention activities for 1,000 high-risk subjects. I'm a vice chair for Worldwide Innovative Network in Personalized Cancer Medicine. And I also lead a not-for-profit initiative called Impact India International, and for-profit called ILON Precision Oncology and Nova Precision AI. With this, thanking you for allowing me to present what is very integral to what I do and what I practice. And I hope to have left a message of screening and prevention with you, and I'm happy to take any questions.
Thank you very much, Dr. Limaye, for this very enlightening session. Of course, it's all very scary. We had Dr. Hemant Ongaonkar last week from the Nanavati Max Hospital, and he was mentioning that, once again, perhaps do it around your birthday, do a screening, and ensure that it is done. We have somebody who messaged me and who called me earlier today about cancer care. He's saying, why is it that uh, there's not just one clear treatment available for cancer care? He says that, there is somebody whom he knows who's been diagnosed, and there was one medical treatment provided, and the second opinion gave another medical treatment provide altogether. So why is it that exists, and why is it to be? I'll tell you what he says. He says it's a bit like astrology, where you find that certain stars are similar of a certain politician, certain well-known person. So you think that a kid who has similar stars will also be like that. So why is it that there's no clear, defined treatment process in cancer?
That's a good question. Actually, there are worldwide guidelines. There are very strict guidelines, but each case is different. There can be nuances to the case, which is where a quick change in what we are recommending is warranted, and there could be difference of opinions, because each case is unique and there could be multiple angles to that case, which would make the answer different for different people.
Right. A very basic question has been asked by Mr. Anil Singh, who says, who gets cancer and how does cancer start?
So I read that. It's a great question, and I think we don't learn about these things, which is why I truly feel that we need to change. We need to bring the cancer education in our schools, because orientation, if something is going to be an epidemic, the orientation has to begin from childhood. So just answering that question, cancer is a regular process in our body. When we age, when we spend time being who we are, our cells get old, they damage. And when they damage, certain genes that are involved in stopping the uncontrolled proliferation, they are mutated, they break down. And so these genes that are involved in stopping the proliferation from happening, when they break down, uncontrolled proliferation starts to happen. And that is why cancer is identified as a disease of aging. And that's why the screening starts at 50. But nowadays, we are also seeing a lot of cancer-related changes happening way earlier because of the pollution levels, because of the epidemiological transition that is happening. And we can see these transformations and tumor suppressing genes getting mutated much earlier, and cancers occurring much sooner than what is expected. So the median age at which you expect cancer is 65, but the median age for India is at least 10 years sooner.
Right. There was a question which was asked by Mr. Shampa Srinivasan, which you answered, which is liquid biopsy facility available across India? And you've mentioned, yes, liquid biopsy is available in India. Easy Check 360 by Datar Cancer Genetics and Cancer Spot by Strand Genetics. There's somebody who's asked about what are the symptoms of stomach cancer?
Yeah, so stomach cancer mostly presents as
I've heard of.
no, a lot of stomach cancers present as issues with bloating, issues with lack of hunger. Some stomach cancers can present with issues with acidity. Some of them can present with lowering of hemoglobin. And sorry, my charge ran out, so I had to plug in. You couldn't hear me for a 30-second
That's
period.
okay.
So
That's okay. Yeah.
essentially, um, stomach cancers can present with these symptoms. It is very important if you are experiencing symptoms for the last 2 weeks. Anyone experiencing symptoms for 2 weeks must get evaluated. And if you've not, participated in screening, so symptom-related screening is also another thing. I was at the Asia Pacific Coalition presenting some data regarding the lung cancer diagnosis here in India. And what was quite stark was 3/4 of our lung cancer cases were presenting in stage 4, stage 3 or stage 4. And the doctor who was sitting next to me was a stalwart from Japan. And he just right prior to my presentation, he went up and he presented how 3/4 of all lung cancers were getting caught in early stage 1 in Japan. And how was that happening? Because they were very quick to investigate. If a patient had a cough, if a patient had any shortness of breath, the slightest of indication the patient was getting a CT scan. So I think symptom-related investigation is also very critical. We need to be paranoid. We need to be proactive. I would rather be that than to pass on a symptom and lead to a late diagnosis. So that's my appeal to whoever is asking the question, go get screened in a focused way. So that means endoscopy. If the person is having issues with GERD, reflux, then endoscopy is the next step to make sure there isn't anything ominous.
But tell me, why, what you're saying is point well taken, but uh, especially with seniors, you have sometimes constipation, a stomach ache. You might be a little breathless sometimes because the air quality is so bad, etc. Now, one can't be doing a check for cancer every time. So, where do you think should it be, and should one just listen to
How
the
does one draw the line?
yeah?
So I think very easily here, I'm going to propagate two things which are beyond standard of care, but nevertheless, I practice myself and I'm not shy in propagating. And if you see, people are already practicing. So, what do people do where they can afford? And if I look at the rich and the famous in the US, what are they doing? Even before the standard of care includes this, people are doing whole body imaging. Yearly whole body imaging is being practiced, whole body MRI or whole body CT scan with contrast is being practiced. And that's where I come in with the multi-cancer early detection blood test. If this blood test was done with a good company, please look at the data. Please make sure that there is published data to validate the presence of these companies, because there are lots of companies that don't have data, that are just very, very early in this game, and they are not validated, and they are propagating, they're selling, they're marketing the blood test. I showed you Annals of Internal Medicine paper, wherein 20 such companies are there present globally in the market. In the market, they're selling the tests, and they may not necessarily be very well validated. So you have to look at published data, you have to look at the number of thousands of subjects screened, and both the companies that I have mentioned have good data and they are validated, especially EasyCheck 360 is tested on 40,000 subjects. And so it is very critical to follow the lead and see which company, and then if the liquid biopsy is done, and that then puts a person in low risk, then truly doing the cancer specific screening should be good enough. But intermediate and high risk, I generally propose whole body imaging as well, at least once a year, so that we are not missing on anything major.
And Doctor, how much does this cost, and is it really covered by, is it covered by insurance?
So a lot of insurers are coming, a lot of corporate insurers are actually coming in to cover whole body imaging. A lot of corporate insurers are also coming to include whole body imaging in their health checkup plans, yearly health checkup plans. But I would encourage to figure out from your insurance coverage whether this is coming in covered. The cost of a whole body MRI is somewhere around 3,000 to 5,000 rupees at screening centers. And at regular centers, it may cost somewhere around 12,000 rupees, a whole body MRI, a screening MRI. But it is somewhere between, 3 to 10,000 mostly. And the cost of the liquid biopsy testing is somewhere around 10 to 12,000. So this is the yearly expense, but I can tell you that this is just the tip of the iceberg we are seeing. This is the next thing that is going to happen, and you will see the costs come down to early thousands. So I wouldn't be surprised if I'm talking to you next year, and around this time, the cost has really come down to a few thousand rupees, because so many competitors are entering the market, and it is only a matter of time when this would be a very common recommendation.
Yeah, we have a question from Mr. Shampat Srinivasan again. In terms of cancer screening and detection, you mentioned about the blood tests, etc. Is there a single unified procedure for any cancer, or is it different for different organs?
So both blood tests that I'm talking about are pan cancer. There are tests that are being proposed for single cancers. Like in the West, you have something called Cologuard, which is being pitched by a company called Signatera. And I was actually traveling in Houston for a meeting, and my cabbie just happened to ask me, "Are you here for a meeting?" And yes, and I'm a doctor, and what do you do? And I'm a cancer specialist. And he says, "Okay, doc, what all can I do to prevent cancer from happening?" And I said, "You need to do a colonoscopy." And he says, "No, my clinician has already done Cologuard testing." So, this is becoming very, very common. Some places organ specific, some places pan sites. But I think that's the name of the game that is going to emerge. Having said that, I absolutely second doing the age appropriate routine cancer screenings. Let's not substitute routine cancer screening by doing these tests, because these are not yet FDA approved for to become standard of care for screening. As you know, screening requires much longer follow-up because of the outcomes that they are following. And so until that happens, we cannot substitute anything. So we have to do the routine screening. For a smoker, we have to do low-dose CT scan of the chest. So if you're doing whole body scan, you're already covering that. But for breast cancer screening, you have to do mammography and sonomammogram at the age of 50 every year, and 10 years ahead if someone has had young breast cancer in the family, 10 years before the youngest member affected by cancer. And of course, I cannot deliberate less upon the fact that those who have had cancers in the family are considered high risk. And so if you've heard me for low risk, intermediate, and high risk, those who have had cancers in the family fall in the high risk category, and they should screen everything.
It's a very scary proposition, but I guess
I'll tell you why I'm this way. You heard me for the last, I think, half an hour or more. I am this way because I'm not just an oncologist. I'm an experienced oncologist now, almost 30 years going into practice. My brother, 10 years younger to me, is a senior medical oncologist at City of Hope in LA. But together, 2 years ago, we could not save our mum. Our mum, we lost her of advanced lung cancer. And I used to be a lung cancer doc in the US. So I realized that we have to change gears. We cannot, we had trouble affording, we had to import her medicine, and we treated her for 2 years at Reliance. Reliance was of great help. But you have to understand that not everybody is going to be able to import and treat. These are very expensive drugs. These are novel drugs. Some of them are only in clinical trials. So if we have to truly win this war, we have to strike early, and we have to become aware as a community. We don't go for well visits to the doctor. We only go for sick visits to the doctor. We have to participate in health checkup activities. And some of the health checkups are actually quite archaic. So we have to practice new age screening measures. And I'm all up in the arms, and I welcome you to join me. I think you're muted.
Sorry,
Doctor.
we have a question from Bomi who asks, is it safer to do an ultrasound rather than mammography for seniors due to radiation? Is it true that a breast biopsy actually causes metastasis?
No. So breast biopsy does not cause metastasis. There is speculation around biopsies leading to metastasis, but that is mostly a myth. And I use the word mostly because there are certain types of tumors that are considered to be seeding the track, but those tumors are extremely rare. And the ways we are performing biopsy now, especially if we are talking about the Mumbai crowd, the ways we are performing biopsies now, true cut biopsies are so precise with the biopsy guns that actually you're not seeing any tumor tracks seeding. So that's archaic, that's all gone, that's in the past. Now we have much enhanced ways of biopsying, and we don't see seeding in the tumor or metastasis. And cord biopsies are the name of the game. That's what we recommend. That's what we perform for diagnosis. And I would be very quick on that to get the diagnosis early so that the treatment can be least and the survival highest. That's one thing. And just answering about the ultrasound, I think ultrasounds are great, but they are great for dense breasts. So young breasts are dense breasts. For us to screen them, we do sonos. But for more mature breasts, you need mammograms. And also for people who have cancers running in the family, especially for those who qualify as hereditary breast ovarian cancer syndromes, we advocate breast MRI, bilateral breast MRIs, which are much more specific and much more sensitive to catch even smaller lesions, because the BRCA positive patients can get cancers within 2 screenings. So 2 yearly screenings, and within that, a BRCA positive person can get a breast cancer that can be lethal. So they need to be screened every 6 months, once a year mammosonogram, and once a year breast MRI, or twice a year breast MRI.
And we have a question from Sunita Verma who's asked, are cysts in breasts safe?
So cysts in breast can be very common, but do not. So I'm actually, my message is to run paranoid. So I'm not on the side where I'm saying sleep on it. So breast cysts need to be verified. Breast cysts, need to be under the care of a good gynecologist or a good breast surgeon. Let them tell you that this is all okay, that this is not anything to the disease. And breast cysts can happen because of very young women. So they just need to be evaluated that there is no history of breast cancer in the family, that there is no high risk, and that these cysts are all benign. Once you've had the ultrasound and they're all benign, you then then you can relax.
Doctor, we have a lot of senior citizens here. There are, 300 people who have gathered here, and there are people who are watching it on YouTube. Uh, we have a message which I'll first read. This is from Kashi Vishwanathan from Bangalore. He says, I lost my dear wife to breast cancer detected late. Uh, and he says that he's aware of the importance of early detection, and he's been advocating all the ladies in his community or family and friends to go for regular screening. Given the message that you've made in this session, uh, the various senior citizens who have gathered here, what do you think they should do to spread the message within their own community, within their own housing complexes, RWAs, etc., across the country? What should they be doing? And also, you know, uh, cancer care. One if one goes to Tata Memorial Hospital, the kind of rush that exists in Mumbai, and there are people from across the country, especially Eastern India, who are there. What should they be doing? Who should they be going to? Is there any message that you would like to make so that people can kind of spread the word?
That's a great question. And I think, it's when I say it's an epidemic, it is a true epidemic without the command centers handling the queries, actually. So, of course, we are really trying to move the government to do their bit, but communities and societies have to rise to the cause and also come together to help the government. And that's where I feel what you're doing and what you did today is huge, because you're inviting folks like myself to come in and spend time, and you're gathering this 300, 500 uh, people in the community to come and listen and then be the torch bearers to spread the message. To Mr. Vishwanathan, first of all, my condolences for his loss. I know what it feels. And then I would go ahead and say, I also know this has been my coping to connect, to talk to people, to spread the word, to really try and make a difference in saving the next lives, not just as a serving clinician, but also someone who joins the revolution against cancer and raises awareness. I think it all begins from awareness. I say this all the time. What the mind doesn't know, the eyes don't see. So we have to all get together to first raise awareness. And if you have any leverage in your community, please speak to people and ask what Vidya Balan asked. Time nikale, screen kare. I think we have to all get together and spare time. Ask each other, aapne screen kare? Aapne screen kare? And like I said, make it a celebration to have a negative screening test, a clean screening test, than to expect something to come out of that expense of 20,000 in a year. But I think currently it is also challenging because our government is not covering, a lot of insurance companies are not covering. And so people like myself, and I request you to join hands with me in appealing to the government to bring about a change, not just in our insurance coverages, but also to the poor, to the ones who are included in schemes, to the Ayushman Bharats of the world, wherein screening should be incorporated as a regular intervention for any suspicious case. So I really plead for everybody to come together and to drive this way beyond a clinician can ever do.
No, absolutely. Most insurance companies, they defray costs only after 60 days of hospitalization, and with maintenance drugs being given, and those are not covered and which are fairly expensive. Doctor, we have a couple of questions. This is Meena Goyal. डॉक्टर मेरी बहन को गले के साइड में कैंसर बढ़ रहा है, सेकंड स्टेज में है, उसके लिए क्या करें?
सो गले के साइड में मोस्टली कैंसर जो होता है वो हेड एंड नेक कैंसर होता है। अगर मैं अज्यूम करूं कि ये वही है, तो आपको इमीडिएटली एक कोई अच्छे हेड एंड नेक सेंटर पे जाना चाहिए और वहां पे उनकी बायोप्सी होनी चाहिए। ऐसे सिचुएशंस में हम पहले कीमोथेरेपी इम्यूनोथेरेपी करते हैं और उसके बाद उसकी सर्जरी करते हैं। अगर सर्जरी ना हो पाए तो कीमोथेरेपी और रेडिएशन होता है। सो अच्छे सेंटर्स में आज मल्टी डिसिप्लिनरी केयर होता है, जहाँ कीमोथेरेपी डॉक्टर, रेडिएशन डॉक्टर, सर्जिकल डॉक्टर सारे साथ मिलके काम करते हैं।
Thank you. We have a question from Sushma Agarwal. She's asked on YouTube, क्या प्रिसिशन ले सकते हैं फर्स्ट स्टेज पर, कैसे पता कर सकते हैं?
सो प्रिसिजन, मैं कहती हूँ कि प्रिसिजन कोई खास ट्रीटमेंट नहीं है। प्रिसिजन इज एन ओरिएंटेशन। ये आपकी मनस्थिति है, आप कैसे कैंसर को देखते हैं, कैंसर को देखने का नजरिया है, उसको समझने का नजरिया है। और हर कैंसर को प्रिसिजन के नजरिए से देख सकते हैं। कैसे देख सकते हैं? स्टेज 1 कैंसर है, अगर उसके फैमिली में भी कैंसर है तो वहां पे प्रिसिजन आ जाता है। अगर स्टेज 1 कैंसर को हम प्रिसिजन के द्वारा अलग तरह से ट्रीट कर सकते हैं तो वहां पे प्रिसिजन आ जाता है। सो हर कैंसर को हम प्रिसिजन के लेंस से देख सकते हैं। इट इज जस्ट एन ओरिएंटेशन to make sure the treatment happens in the best way and the least troubling way, least toxicity.
Doctor, I know we've exceeded time, but I have two more questions. One is from Mintu Gupta. क्या stomach में polyps से cancer हो सकता है?
पॉलिप्स जनरली बेनाइन होते हैं, पर एक तरह का पॉलिप्स जो होता है वो कैंसरस भी हो सकता है। सो व्हेन यू टेक द पॉलिप्स आउट एंड इफ द पॉलिप shows dysplasia, that is en route to cancer formation, that is a polyp that is dangerous. And in that situation, sometimes doctors recommend doing a prophylactic surgery of the stomach, but not all polyps are cancerous or precancerous.
Okay, I need to increase my question by one. This is Sunita Verma who says, I have BIRADS category 2 in my mammography. Is it worrisome?
No,
All right.
BIRADS is benign.
Okay. Doctor, this is another question that has come in. Doctor, I have uh, uh, got an opinion from a medical oncologist for my wife. I've also got a second opinion from Tata Memorial and MSK. I've just seen your session. Is it possible for me to get an opinion from you? And how does one
Yes,
do that?
no problem at all. And so, normally I would say we would circulate my details, coordinates after the meeting.
Right. All right. Thank you very much, Doctor, for this session. You know, we've been doing, as I mentioned earlier, we've been doing sessions from June 2000, and this is the first time we've had 300 participants, 300 attendees in this thing, which is a great thing, but it's also a little scary because that is the kind of awareness that is required, for cancer care, and I must thank you very much. Thank you to the team at.
I just want to say one last thing. We just launched on World Cancer Day, we just launched an app to help patients with navigation. It's a not-for-profit. And there we are saying, remove the S from the scare from cancer. And
And
truly, you're not scared of a subject, will you take it on head on? And that's my hope and wish. And that's the message that I want to leave with. And truly grateful for this opportunity. Thank you for having me and power packed discussion.
thank you very much. And I'm going to invite you to write for us for Seniors Today, because I think, it's important. And I think you've been very candid in your message. One couldn't have been more direct and candid in the messaging. And it's amazing that has been there. Even as I was listening to you, and I said, gosh, should I be doing a whole body screening myself? And I was, coughing when you were chatting, and I said, gosh, now, could this be what it is? But thanks very much for this session. We've been getting a lot of thank yous from on the chat. So
For listening in.
Clearly.
Thank you.
And thank you to the HN Reliance team for facilitating this. Thank you.
Thank you, sir. Thank you. Bye-bye.
We will be back again next Saturday for another session of Health Live at Seniors Today.